Thank you, ma'am. At the outset, I would like to thank Dr. Namrita for a beautiful assembly of this course, which she's been successfully running for, I think, over 5-6 years right now. So some of you might have seen some of the contents of my talk, which I'm going to present now. Now, I'm just giving you a broad overview of how you would approach a case of microbial keratitis. The speakers coming in after me would be elaborating specifically depending upon the various microorganisms they're going to speak upon. So, how would you approach or work up a case of microbial keratitis? I'll be walking you through my talk on these lines of definition, stages, classification, workup, clinico-microbiological correlation, and management, and how every aspect of these, what I'm mentioning here, is going to be important or related to your microbial keratitis workup. When we define ulcer as a discontinuation in the normal epithelial surface of the cornea associated with necrosis of surrounding corneal tissue, when you're looking at an ulcer, it could either be in the progressive infiltration stage, an active ulceration, a regression stage, or cicatrization stage. The stage at which you're looking at the ulcer, it's also going to depend upon the management approach you're going to need in these various stages. Once you're looking at a progressive infiltration or an active ulceration, you need to scrape the ulcer. Your workup would be directed towards the diagnostic modalities per se first, and then the therapeutic modalities for helping in achieving optimal healing in these patients. Once you're seeing a patient in the stage of regression, you know much of the infective load is already gone, and you probably have to decrease the amount of topical antimicrobial therapy required and add on elements which would aid in epithelial healing. Once you're looking at an ulcer which is going into the stage of cicatrization, you know that the infective modalities is almost totally gone, and you're going to need to add on agents which are going to help in reducing the amount of stromal scarring you're going to achieve in these patients. The treatment modality or will again depend upon the kind of microbial organism you're dealing with, but not always is your lab is going to give you a supportive answer in terms of what is the etiological agent. So much of the clinical examination is important in giving you an empirical diagnosis of what this ulcer is possibly going to be. But you should also remember that it is not necessary that the clinical impression is always the right impression, and you probably will have to also look at the way the ulcer is progressing and how it is responding to the treatment you have instituted. You also need to know whether the ulcer is superficial or deep, and superficial per se because that's going to give you a rough idea of what kind of an ulcer you're dealing with. And in deep keratitis, again, you're going to think about what is going to be the diagnostic modalities you're going to approach, or what is going to be the specific treatment adjuvants you're going to give for effective healing of these ulcers. You could also classify an ulcer according to the amount of suppuration which is involved. But classically, we would talk about them as being mild, moderate, or severe ulcers, depending upon the size of the ulcer, the depth of the ulcer, the location of the ulcer, and the anterior segment involvement. These primarily are going to necessitate in deciding, apart from the diagnostic and therapeutic modalities, again, if you're going to need to think whether you're going to give monotherapy for these patients, combination therapies for these patients, these factors of the size of the ulcers, the depth of the involvement of the ulcers, and the amount of anterior chamber reactions all play an important role, and also whether the visual axis is involved or not is going to play a major factor in your further approach or your further progression in the way you're going to look at it. When you're going to talk about the workup, the clinico-microbiological correlation, and the management, so first what you would do, you would identify the risk factors which have probably resulted in causing this ulcer. Could vary from identifying the etiological agent for this ulcer, the contributory ocular or systemic comorbidities which have existed, which have resulted in the formation of an ulcer. For example, a rheumatoid arthritis patient, for example, a patient with other immune diseases, a patient who's had a chemical injury for the eye. So there could be various associated ocular comorbidities which have probably precipitated the occurrence of an infectious keratitis agent, which also needs to be identified, and not look at an ulcer just as an ulcer, but also wonder why this actually happened, which goes a long way in early healing and effective management of these patients. The clinical workup of the ulcer I will subsequently be talking to you about, and you will also have to aid your clinical workup along with a microbiological workup, which is always the traditional, the smears, the cultures, and of course we have the most advanced, the advanced molecular techniques for helping you in diagnosis. Systemic evaluation to look at the systemic factors which have been contributing to the formation of these ulcers. And we have specific diagnostic modalities like confocal microscopy and corneal biopsy, which will help you in deciding how you're going to proceed, especially in cases where you're not able to make a proper diagnosis and your therapeutic modalities are not being effective. Another important factor today when you're looking at management of keratitis is we have various options. So when you're examining the ulcer patient, you have to understand which of these modalities where you need to be adopting as an adjuvant therapy to topical antimicrobial therapy, whether you need to give intrastromal injections, intracameral injections, especially for deep, non-healing, recalcitrant chronic keratitis patients. Whether if it's a superficial ulcer or whether it's a deeper ulcer with an impending melt, you need to treat them with cyanoacrylate blue or bandage contact lenses. And if you see it's an eye is gone to irretrievable damage and losing tectonic integrity, perhaps you don't need to do a therapeutic for these patients, but take them on with conjunctival flaps. And of course, the traditional for chronic non-healing ulcers or to debulk an infective load is therapeutic keratoplasty and tectonic ducts. So in a nutshell, evaluate risk factors. Risk factors also take the history of use of ocular medications for chronic use of acyclovir, chronic use of topical steroids, chronic anti-glaucoma agents, all contribute to occurrence of infectious keratitis in patients as well who are on long-term medical therapy, and also look at the factor of their compliance to medical treatment. Apart from systemic features like diabetes, Stevens-Johnson's, immunocompromised individuals, malignancies, alcoholics, and extremes of age, you'll probably want to rule out other factors like trauma, chronic contact lens wear, microbial keratitis, microsporidial keratitis such as this, adjuvant adnexial infections which can lead to blepharokeratoconjunctivitis lesions, ocular surface disorders such as SJS, OCPs, chronic chemical injuries could be associated with infectious keratitis as well. And this is a bandage contact lens induced ulcer in a pseudophakic bullous keratopathy patient who was on long-term use of bandage CLs. Topical medications such as long-term acivir therapy, long-term topical steroids can also lead to ulcers. And of course, don't forget the neurotrophic keratitis. And occupational therapies also, as farmers, gardeners, animal handlers, those in laboratories are all prone to a higher risk for especially fungal keratitis. You have to examine the ocular adnexia because sac infections or blockages in the lacrimal drainage system can also lead to chronic keratitis conditions because the conjunctival sac remains flooded with the microorganisms. Look at the ocular adnexia for signs of viral infections. And it goes without saying that the preliminary examination modalities of visual acuity, slit lamp biomicroscopy, all need to be taken seriously and done methodically. So look for lid edema, blepharospasm, chemosis, the area of ulceration, infiltrations, margins, the ulcer flow, necrosis, stromal edema, the presence of anterior chamber reactions as in terms of hypopyon, iritis, keratic precipitates, look at the pupillary reactions, the lens status, and an associated endophthalmitis as well. So in a nutshell, I think I've almost covered most of what you need to look at when you're looking at a corneal ulcer. The documentation is also very important for these patients. It just could be photographic documentation or could also be simple good diagrams to see how you're going to do. Thank you.